Welcome back, students. I am so thrilled to have you here for part 85 of our IPDRG Masterclass. Today, we're building our ultimate authoritative guide to the high-stakes, highly complex world of the nervous system. We are going to jump right into this explainer because the concepts we're covering today, well, they form the very backbone of critical care coding. But real quick, before we get into the weeds, I do need to deliver our opening call to action for our dedicated learning community. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely what keeps this comprehensive education free and accessible to everyone. All right, to set the stage, let's just do a super quick recap of where we came from and where we're headed. In Part 84, we navigated the really intricate pathways of MDC-04, right? We looked closely at thoracic surgery and interventional pulmonology. But today, for Part 85, we're transitioning into MDC-01, the nervous system. Basically, we're moving from the chest up to the brain and spine. It's an incredibly high-acuity landscape, and the precision of your clinical documentation here can literally make or break a hospital's revenue cycle. So, here is our agenda for today's masterclass. First, an MDC-01 overview. Second, we'll hit high-volume medical DRGs. Third, we'll cover CDI validation and audit defense. And finally, number 4, a quick summary and a teaser for Part 86.
Section 1, MDC-01 Overview, Mapping the Nervous System Landscape.
So the nervous system category is a massive primary driver of ICU admissions, long-term disability, and emergency transfers. And what's really interesting about how it's laid out is its fundamental structural partition. Essentially, every case gets funneled into either medical or surgical DRG logic. If a significant operating room procedure is performed, say a craniotomy, a spinal fusion, or an endovascular thrombectomy, boom, the case gets pushed into a surgical DRG. But if there's no major OR procedure, we live entirely in the medical DRG partition. This side captures life-threatening conditions like ischemic strokes, intracranial hemorrhages, and seizures. Speaking of seizures, you have to be super careful to document whether it's a transient unprovoked seizure versus recurrent epilepsy with status epilepticus. But today, we are laser-focused purely on this medical side of the house. Section 2. High-volume medical DRGs, navigating stroke, hemorrhage, and seizures. Okay, this sequence here brilliantly illustrates a question I get all the time in our field. How on earth do you code an aborted CVA? Picture this. A patient rushes into the ER presenting with acute stroke symptoms. The medical team is on it, right? They immediately push IV TPA or tenecteplase, powerful clot-busting drugs. And because they acted so fast, a follow-up CT scan shows absolutely no visible brain damage. Naturally, you might be tempted to say the stroke was averted entirely. But here's the critical rule for MSDRGs 061 through 063. You must code this as a completed CVA. Why? Because even though brain damage isn't visible on a macro level on the scan, microscopic infarctions are absolutely present. The patient actually had a cerebral infarction.
That brings us to a crucial point. You have to know the strict diagnostic boundaries between a transient ischemic attack, or TIA, and a completed ischemic stroke. A TIA is strictly temporary. The symptoms resolve completely, and there is zero infarction. An acute CVA, on the other hand, involves actual tissue death, even if it's just microscopic. We have to make those clinical boundaries crystal clear in the documentation. And we need anatomical specificity, too. Was it a thrombotic or embolic infarction? Was it in the cerebral or precerebral arteries? If a physician just writes stroke-like symptoms, you are practically inviting payer audits. They will downcode that to a simple TIA in a heartbeat, misrepresenting how sick the patient actually was and totally decimating your DRG weight.
Let's pause for a quick knowledge check. Think about this. When exactly do we capture the Glasgow Coma Scale, the GCS, and the NIH Stroke Scale, the NIHSS, for our coding? I really want you to think about the specific, rigid rules governing these neurological assessments. All right, here are the exact criteria you literally just have to memorize. The Glasgow Coma Scale is only coded for traumatic head injuries, intracerebral hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. That is it. Conversely, the NIHSS score is specifically reserved for acute CVA cases only. You absolutely cannot mix these up. Applying the right scale to the right etiology is totally fundamental for clinical validity and getting the precise IPDRG assignment. Now let's shift gears to another massive area in MDCO1, and that's encephalopathy. By definition, this means any disorder, disease, or malfunction of the brain. It's a high acuity condition, and it manifests in several ways. You've got metabolic encephalopathy, which is driven by chemical imbalances. You've got toxic encephalopathy from drugs, and hepatic encephalopathy linked to liver failure. When you look at these, alongside conditions like bacterial or viral meningitis, which fall under MSGRG 070 to 072, and acute neuromuscular crises like Guillain-Barré syndrome under MSGRG 091 to 093, accurately capturing the specific type of brain malfunction is absolutely paramount.
Section 3. CDI Validation and Audit Defense, Protecting Revenue Integrity. So, as we always talk about, it's not enough to simply know how to assign a code. You have to be able to defend it against aggressive commercial payer denials. Thinking about the grouper logic, I want to remind you how this all connects. Your principal diagnosis gives you the base DRG, but it's our secondary diagnoses, the CCs and MCCs that truly influence the severity level and the reimbursement. If you capture conditions like encephalopathy, post-stroke dysphagia, hemiplegia, noting if it's the dominant or non-dominant side, by the way, or acute respiratory failure requiring invasive mechanical ventilation, you add significant weight to the DRG. The payers know this. That's exactly why they actively audit and try to downcode these MCCs to simple symptoms if your clinical documentation is even slightly weak.
And this is exactly how we fight back. If a physician documents metabolic encephalopathy, you need to immediately map that to the clinical indicators in the chart. You are looking for altered mental status, GCS drops, or specific EEG findings. You're hunting for lab values like elevated ammonia, severe hyponatremia, or uremia. You also need to look for the underlying driver. Was it sepsis, a bad UTI, alcohol withdrawal? If the diagnosis is vaguely documented but the clinical indicators are glaringly obvious, craft a compliant physician query asking for the acuity of the condition. Pairing the diagnosis with these undeniable, objective indicators is how you build an ironclad defense against payers trying to downcode a severe MCC to simple delirium.
That same rigorous validation applies to cerebral edema, which is another incredibly powerful secondary CC or MCC. You can't just code it simply because the word edema is floating around in the chart. You have to look for the clinical indicators justifying it. Was there a traumatic head injury, an intracerebral or subdural hemorrhage? Does the patient present with severe memory loss, a stroke, or seizures? And don't forget to look at the clinical management. Are they receiving treatments like osmotherapy or hyperventilation? Tying the actual diagnosis to these specific indicators and physician management steps is what ensures an accurate, fully defensible MSGRG weight.
Section 4. Summary and Part 86 Teaser, our final review.
Okay, here are your major takeaways for today. First, always remember that MDCO1 is strictly partitioned into medical versus surgical DRG logic based on major OR procedures. Second, an aborted CVA treated with TPA is absolutely coded as a completed CVA because microscopic infarctions have occurred. Don't let that trip you up. Third, metabolic encephalopathy is a massive target for audits. Defend it vigorously with clinical indicators like altered mental status, elevated ammonia, and hyponatremia. And finally, meticulously capture those secondary CCs and MCCs like cerebral edema to ensure the true clinical complexity of your patient is accurately reflected in that final MS-DRG weight. Up next, we'll be diving into Part 86, where we transition to the other side of MDCO1 and explore advanced surgical DRG logic, specifically looking at neurosurgery and spine procedures. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
Now, I want to leave you with one final, provocative thought to take with you to work tomorrow. If a commercial payer challenges your metabolic encephalopathy code, claiming, oh, it's just the patient's baseline dementia, what specific, rock-solid clinical indicators are you going to pull from that chart to shut that denial down? Think about those lab values, the acute changes in the Glasgow Coma Scale, and the underlying toxic or metabolic drivers. I want you to apply this knowledge immediately on the very next chart you look at. Thank you so much for joining me today, and I will see you in Part 86.